suicide. Yeah. I mean, pretty much everyone in the room. So it's not anymore an if, it's a when. And it's really important that we start to think a little bit differently about how we care for people at risk for suicide, how we work with people at risk for suicide, how we think about suicide. And so because the numbers are growing, I never thought that I would use pediatric and suicide in the same sentence as much as I do now. I was doing a postvention yesterday for an 11-year-old that took their life. And so people always ask, well, you know, what do we need to do differently? I think we need to do lots of things differently, but we need to do more, right? We need to try to create a world where we don't have 11-year-olds that feel so hopeless they die by suicide, right? So a couple of things that we want to start to really think about is our language. You noticed I said die by suicide? How many people still commit suicide, right? Language, we've been using that language for so long. People die by suicide, they commit crimes. Also, words like satisfactory or completed or uncompleted, successful, unsuccessful. I've been in so many, I was in an emergency room one day and there was a 13-year-old who tried to die by suicide, and they said, I want you to meet so-and-so. She had an unsuccessful attempt. Right? But that's language that gets used a lot. So what are we saying to that 13-year-old? Well, gee, yeah, you can't even die by suicide successfully, or had you been successful, you wouldn't be here, right? And so really looking at our language, right? Also the behaviors. It's so interesting to me. I get to go look at a lot of medical charts. And in the medical charts, even in the electronic ones now, because I'm old, I remember paper charts, and in the electronic charts, it's always amazing to me in capital letters. Patient is manipulative. Patient is attention seeking. And so I don't know about you, but I don't pretend to know someone's intention. I tend to get in trouble a lot, and so I find myself saying a lot that wasn't my intention, right? I didn't intend to do that. I didn't intend for that to happen. So I never pretend to know someone's intention. What I do know is that if someone is with me or talking to me and they're talking about suicide, they're more likely to die by suicide. And so I just start there. Also, it's not so helpful to my team if I say patient was attention seeking. What's more helpful is what did they say, what did they do, what actually happened. So we want to kind of take those words, right, out of our vocabulary. I also very much like caring for as opposed to working with. How many times, so I was interviewing somebody yesterday and they said, well, that's how I just deal with people. And I was just like, and you want to know the truth? That tanked it. Tanked the whole interview, right? So that's not really language that we want to use. So when we think about suicide and we think about other public health, we think about car accidents, we think about, flu, we think about some chronic illnesses. The number of suicides is starting to really outrank people that are dying by other means, starting to be the number one cause of death in some populations, right? And so one of the things that we've been talking a lot about is given the number of people who die by suicide, we're not spending the amount of time training people how to care for people who are at risk for suicide. How many of you got trained, special training when you were in school about how to care for somebody at risk for suicide? One person. The head of suicide prevention for the country actually says that the only class he ever took on how to care for people at risk for suicide was one he taught. And I recently had to do a training. We were going to teach students for this grant we got, master's level students in social work, how to care for people at risk for suicide. And one of the faculty called me and said, we had the faculty meeting, we decided you should train us first because we don't actually know. And so really important to start to think about how many people. So why are we starting to really think about healthcare? Couple of reasons. Most people who die by suicide saw their primary care provider in the month of death. The other thing we've learned is that if I'm disengaged from care, I'm not seeing anybody, not dental, not mental health, not my primary care provider, right? I resurface into care, into primary care the month of my death for an average of 2 visits. So I resurface into care. The other thing that we know is the electronic health records have patient portals. Patients are more active on the patient portal the month of death. So much so that the VA actually considers it a risk factor, right? They watch for it. So people are reaching out. So when we think about seniors, unfortunately, about 1/3 of the seniors don't get the behavioral health services that they need. So many times I have people say to me, well, they're old. Of course they're sad, right? All the time, I still have people say that to me. I had a primary care provider say it to me not that long ago, right? And so we also know that they make up just under 20% of the suicides. So a lot of times we don't even think about them being at risk for suicide. So what are some of the biggest risks for suicides in seniors, do you think? What puts someone at the most risk? Yeah. Huh? Yeah, living alone and losing a partner or a spouse. Losing a partner or a spouse is the #1. And getting a chronic illness that's going to affect like ambulation and things. So really important to ask seniors. How about our youth? It is shocking to me. 8.9% of the students tried to die by suicide, not thought about it, actually had an attempt. So how many of you have kids or grandkids in high school? Okay. So how many kids in a class? About 30? So when you think about it, about 3 classrooms full of kids, more than 8 of them will try to die by suicide this year. So next time you're walking down the hallway of a high school, count every 3rd classroom and that'll tell you. So starting to think about. The other thing is that very lethal attempts. Does anybody know the #1 way that adolescents try to die by suicide? Hanging. Second is jumping off buildings, starting to be rivaled with guns. So how many of you work in healthcare places, right? Everybody, Joint Commission, you all heard, we love Joint Commission, right? So Joint Commission, all of them are finally saying, like, you got to do something about suicide. Like, you can't just, not do it. You have to think about it. You have to have a pathway. You have to start doing something formal. I really like, this is actually a very famous zero suicide slide about like the holes in your system, right? So one real common way that people fall through the cracks is we had someone die by suicide and she canceled 3 appointments, like a primary care appointment, a women's health appointment, and like some kind of nutritional counseling visit. And nobody at the front desk knew she was at risk for suicide when they took the call and she was canceling. And there was no system in place to know that she had canceled 3 visits in a short period of time. So sometimes it's really important to think about places where people could fall through the cracks. That person picking up the phone didn't know to do anything different because they didn't know that that person was at risk for suicide. And so thinking about ways that you can plug some of those holes is really important. I like to think about it as like wrapping a warm fuzzy blanket around our people that are at risk for suicide so that they don't fall through any holes in our system. If you haven't been to the Zero Suicide website, go. It's got some really cool trainings. You can get some continuing education and really talks about some things that you can do organizationally to help you think about suicide. So we have gone around the country and talked to a little over 3,000 primary care providers and their teams in about 30 states, and there's lots of things that we heard. One of the things we heard is that more than 95% of the primary care providers, regardless of their discipline, said, yeah, I think it's part of my role. About 44% of the behavioral health people in those practices said, I don't feel qualified or competent to care for somebody at risk for suicide. So we really need to try to do something different. So a lot of people said, I don't know what to do, right? I don't know what to say or do. So there's one thing that saves lives more than anything else. What saves more lives than anything else? Time. Active listening and giving somebody resources and hope. Yeah. People who have hope don't die by suicide. And anybody can give someone hope. We can all, regardless of our background, we can all give someone hope. So one of the things that I found is really important to do is to have what I call storage statements. So I get the pleasure of teaching people going into behavioral health, baby social workers and psychologists that are, doing treatment. And sometimes when they're working with patients, they would get a little discombobulated and they would kind of forget. And so we came up with this thing called storage statements that they could say in almost any situation to kind of give them a little second to get back grounded, right? And so we thought about, well, what about storage statements for people who are at risk for suicide? Because sometimes when people tell you they're thinking about suicide, maybe you weren't expecting it, right? And so it's helpful to think about, what would I say to someone who just told me, maybe for the first time, that they're thinking about suicide? Because I don't know about you, but there's times in my life when I've told somebody something, maybe for the first time, and that first couple of seconds after you tell them, you're like, should I have said something? Do I regret this? Like, will I ever say anything again, ever, right? Or this was a cool idea, it helped me, I feel better, right? You can tell right away. And so when someone tells us that they're thinking about suicide, maybe the first time they've ever told anyone, what do we want them to know? So in 2 or 3 sentences, what do we want them to know? What do we think? Yeah.
Thank them for sharing.
I love that, yes, and you're not even paid back there in the corner, yes. Thank you for telling me you're thinking about suicide. And I always say suicide, like, I heard you. Thank you for telling me you're thinking about suicide. What else do we want someone to know?
I'm here for you.
I'm here for you. Yep.
I care about you. I want to help you.
I care about you. Your life is important to me. Your life is important to us here at the center. What else? I have hope for you. I can see it took a lot of strength for you to tell me. So what's our storage statements? Thank you for telling me you're thinking about suicide. I have hope for you. You're important to me. We care about you here. So tonight, on your commute home, or when you're brushing your teeth, it's really important. Think about a couple of things that you could say to someone who just told you they're thinking about suicide. And you don't know, this could be someone you're caring for at work, it could be a neighbor, it could be someone in your family, And it's going to be super important because then you're like, I got this, I know what to say right away. Super helpful to be able to do that. And I've had so many people come back to me and say, you know what, I didn't really do that storage statement thing after you told me, even though I promised I'd do it when I was brushing my teeth, but man, was I glad I remembered yours. So really helpful to think about. I would also say practice at a staff meeting. Practice with your family. This isn't just a skill all of us need to know. I practice with my daughter's college dorm mates, right? So you can practice at the dinner table so that everybody knows what to say when someone tells them they might be at risk for suicide. The other thing that we heard a lot, how many of you work in primary care practices? So, I love working in primary care, I miss it. And so one of the things we heard, which was totally predictable, is like, I don't have time. I have a 15-minute primary care visit. I don't have time, right? Heard that? Yes. And so I like to tell a little story, which is actually a true story. And my husband knows I tell it now. He didn't know for a while, and then he overheard it. So then I realized I had never actually told him I was sharing the story. So he got hit by lightning, true story, and lost a good chunk of his hearing, which is better now, but still incredibly frustrating when you're standing on one side of him. And so we went to the primary care provider, and lovely medical assistant took height, weight, blood pressure, all of that, and then kind of left the room. And I was like, it's a little weird. But like I had promised to be an observer on the way there. One word. Did not say one word, right? And so a little minute or two later, the primary care provider came in. And she took his blood pressure. And I'm watching this. And I'm thinking, So she says to him, I'm worried about you. Your pressure's through the roof. I'm not sure you're going to be able to go home today. Asked him some questions, got some information, said, listen, I'm going to go see my other patients, I'm going to come back, and we're going to figure out what to do. So she did. A couple minutes later, she came back. We never talked about his hearing loss the entire rest of the visit. Wasn't important anymore. It was only about his pressure. Turns out an ambulance ride and one stent later, right? But the point is that we do that all day long in primary care. Like it would be a beautiful thing in primary care if somebody came in for one thing or came in for the one thing that actually was front and center, right? Like we switch gears all day long. Like that's all we do. We do it better than anybody else. And so whether his blood pressure had been through the roof or whether he had said, yes, I'm thinking about suicide, it doesn't matter. We stop. We ask some questions, we get some information, and we figure out a next step. So we do it all day. So this is not doing anything different in primary care. We already do it. So we don't want to panic, right? We want to use our storage statements. So how many of you screen for depression and use the PHQ-9? Fabulous. We're going to talk about that for sure. So it's super important to ask patients what you want to know. I used to work in family violence and intimate partner violence, and a lot of times I used to ask people, how do you ask people about family violence? They say, well, I ask them if they're okay. And I'm like, well, I'm not okay today because my dishwasher broke this morning, right? Like, that's not what you want to know, right? So you want to ask what you want to know. Is someone hitting or hurting you at home, right? That's what I want to know. I want to know, are you thinking about suicide? So it's really important. It's not asking about whether or not you're okay. It's not asking about whether or not you want to hurt yourself, because I might want to hurt myself if I'm an adolescent and I caught two different things, right? I want to know if you're thinking about dying by suicide. So we should ask, right? And the research overwhelmingly says Asking is not giving someone an idea. I was with a pediatrician. She was lovely and she was very sweet. But when I asked her, she actually whispered back to me, "We don't want to ask about suicide." And I said, "I'm not sure why we're whispering. One, because we're the only two in your office, but two, like, your patients already know about suicide. They know who Kate Spade was, trust me, right? Like, they know about suicide. They saw 13 Reasons, like, they know about suicide. So you're not giving anyone any suggestions. They already know." Also, this was really different from how I was trained. Many people who die by suicide don't have a mental illness at the time of death. Very different from how I was trained, right? I was actually trained, well, you're going into the mental health business, you're going to lose some people to suicide. Now I know that's crap because all suicides are preventable, right? We know that now. So really, social determinants play a huge role. Relationships, housing, finances, employment, huge role. We had a provider stand up at one of these trainings and she said, "You know, I had this patient, we were really worried about him. We went to see him, the team went to see him, we brought him in, we called him. He died by suicide about 2 weeks ago. And now that I think about it, he was absolutely at risk for suicide. He had increasing health issues, he couldn't work, they were having financial problems, was causing problems in his relationship, they were at risk for losing the home, he started to drink more than he should. We never asked him about suicide." So those social determinants put people at a huge risk. Substance abuse and alcohol, of course, right? And also transitions. We think about transitions, someone coming out of the hospital. But that's actually not the only transition that puts people at risk. So I've been doing some work with big brothers, big sisters, and they're starting to ask all the littles. That's the big brother, big sister lingo now. I have bigs and littles. So they ask all the littles about a geographic move, or they pay attention to when a child moves schools or moves geographically because it puts them so much more at risk. So coming out of substance abuse treatment, foster care, incarceration, any of those transitions really put people at risk for suicide, and you should ask them about suicide. So, and many people who die by suicide don't have depression. Anxiety is actually a huge risk factor for suicide. And now we see more anxiety than we see depression a lot in primary care, right? So one of the things that we really encourage people to do is to put suicide on the problem list so that everybody knows about it on the team. And sometimes people will say to me, "My patients will not want suicide risk on the problem list." And I say to them, that has not been my experience. Couple of reasons, but one I say to people is, you know, thank you for telling me that you're thinking about suicide. You're really important to me. So I just want to let you know that I'm putting that we talked about your thoughts of suicide in the chart because I want to make sure every time I see you or my team sees you or I talk to you or my team talks to you, we make sure you're safe. I've not had anybody say no. And I ran health centers. We had about 110,000 patients, and I think because I was the behavioral health person, they decided I was the one that should get all the complaints from people who looked on the portal and saw something that they didn't like. So I used to get all those complaints, right? I know it's what happens when you're the behavioral health person, right? And so I would get all those complaints. And I never once got a complaint about suicide on the problem list. And I had thousands of patients with suicide on the problem list. You know what the number one was? Morbid obesity. I kid you not, every week. Does this really mean I'm that fat? Am I gonna die? Why is this in my chart? I kid you not, every single week. Never one suicide. A couple HIV, a couple STDs, never one suicide. And so, super important. And also, a lot of times we pay a lot of attention to what's going to happen the first time we talk to someone who's at risk for suicide. And someone says yes, right? We ask them about suicide, they say yes, I'm thinking about suicide. And we think a lot about what we're going to do, but we don't think about when they come back. Like, how do we care for them ongoing? So like, there was a young adolescent, and he went into a school-based health center to get some forms filled out, right? Said yes to suicide question. Lots of commotion, sent him out, right? 3 weeks later, he came back. Same forms, different provider, got his forms filled out and left. No one asked him if he was safe. No one asked him if he was connected to care. No one asked him about suicide because it wasn't on the problem list in the chart and because there was no process to follow up. So I have diabetes. Every time I go into the primary care provider, there's things that I do because I have diabetes. And yes, you did see me eating those cinnamon rolls, and that was bad. But in my defense, they were really good cinnamon rolls. And so I kept cutting a little piece and cutting a little piece, and finally I was like, Virna, who are you kidding? Like, just... And so, but they ask me things every single time, right? They have a process. Some I like more than others, but they have a process. And it should be the same. Every time somebody comes back, we ask them, are you safe? Do you have a safety plan? Like, at a very minimum, right? And so we need to start thinking about and doing that. As I've been traveling around the country and doing some of these trainings with primary care, I ask people, tell me about how many of you know how many diabetics you have? And they're so proud to tell me, oh, we have this many diabetics, and we have a registry, and we track the A1Cs, and we hired a diabetes educator. And I'm like, that's fabulous. And it is fabulous, right? How many people do you have at risk for suicide? Crickets. Crickets. Except for one doctor in Wyoming, and I told him he didn't count because he was going to retire and he knew how many patients he had in his practice, like on both hands. I'm like, you don't count. And so, but nobody. There's no structured data way to know that. So like, how do you even know what to do? Because you don't even know how many people you have. Like, how would you know what to do with your diabetics if you didn't know how many there were, if diabetes wasn't on the problem list, if you didn't have a process, if you didn't have a registry? And yet, look how many people are dying from diabetes, and look how many people are dying from suicide. So really needing to rethink what you're doing. And you can add it to the problem list. You could do that today. It's there. It's in every EMR. So this is the PHQ. You all know, right? Everybody knows. Everybody loves the PHQ. I love the PHQ. That's a whole different workshop. But a lot of times for the PHQA, which is the adolescents, people are putting the ASQ, which we'll talk about, the 5 questions to ask about suicide, right at the bottom. NIMH says you should routinely ask 10 and up about suicide. Under 10, if it gets mentioned or somebody thinks there's a risk, but ages 10 and up, you should routinely ask them specifically about suicide. So now, the PHQ is great. We actually know that question 9, if people answer yes to question 9, they are more likely to die by suicide. They're also more likely to die by homicide and other unintentional deaths, but they are more likely to die by suicide. And so, but we also know it is not necessarily enough these days to just ask question 9. It's better than nothing. But what I do, actually, is I take the PHQ-9, whether it's on the computer or paper, however you do it, and I just go through it. And I say, so I can see you're having difficulty sleeping, and that's a problem for you most days. And I can see that you're having difficulty concentrating, and that's a problem for you nearly every day. And those are maybe related, and we definitely want to see if we can't get you sleeping better, right? I also see that you have thoughts that you would be better off dead or hurting yourself in some way, and that's a problem for you several days. So thank you for telling me you're thinking about suicide. Your life is really important to me. And I know that it took a lot of strength for you to tell us that you're thinking about suicide. So what I'd like to do is I'd like to just start there, and I'd like to ask you some additional questions. So I just flow right through my PHQ-9. I'm just going over what you told me. But we're going to start with the suicide question because that's going to be the most important. So it's just kind of like a flow. This is the ASQ. There is a really nice toolkit on the NIMH website. There are only 2 evidence-based tools to really screen and ask about suicide. One is the ASQ and one is the Columbia scale. And so the ASQ, I personally like it better for children and adolescents. If you talk to folks, people will say, oh, well, they're evidence-based for both. That is true, they're not lying. Although the evidence is a little stronger for the ASQ in the kids and adolescents. And I like it because it's just 5 questions. It has a parent's guide, a nursing guide. It's just easier to use. A lot of pediatric emergency rooms use it. It's easily plunked on the bottom of the PHQ-A, so it is nice to be able to use. So one of the things we want to learn how to do is how to get people to the appropriate level of care. Because we don't want to send everybody to the emergency room, right? And I worked in an emergency room for 17 years. I was actually, Patty and I were talking about it last night over really good Mexican food. And, you know, there's no magic that happens there. I sent most everybody home, right? And I was actually, based on what time of the night it was, more or less cranky about the fact that they got sent there in the first place when they didn't really need to be there, right? And so nothing magical happens in the emergency room. In fact, they use the same tools that we're going to talk about. So not necessarily the best choice. In fact, we know that sending people to the ER when they don't have to be there actually puts them at more risk. That's out there. We know that for a fact. So we want to try to figure out how do we assess risk and have some better understanding of what risk is, right? So that everybody can have a better understanding of what risk is. So this is the Columbia scale. We affectionately call it the primary care version. How many of you are familiar with the Columbia scale? Awesome. So what I like about this is that it's color-coded. And so we can do different things for our yellow, orange, and red patients. Because one of the things that really matters is intent. I can think about suicide, right? 66% of our high school kids do, right? Probably people in this room, okay? So I can think about suicide. I can know how I might die by suicide. Do I intend to die by suicide? That is the key, right? Have you had these thoughts and had some intention of acting on them as opposed to I had the thoughts, but I definitely wouldn't do anything about them? Have you started to work out or worked out the details of how to kill yourself? Do you intend to carry out this plan? So that's the intent piece. I had a gentleman in Poughkeepsie, New York. I don't know if anybody's ever been to Poughkeepsie, New York. There's nothing to do in Poughkeepsie, New York, except for one thing. There's like an old railroad bridge that they turned into a walkway, and it goes over the Hudson River. And so he got sent to me because he had talked about suicide to the primary care provider. And I said, you know, thinking about suicide? He said, sometimes. And I said, well, you know, how would you die by suicide? I would go to the Mid-Hudson walkway. And they put up a fence now, so it's going to be a little bit harder. And I don't want to land on Route 9, which is the road that goes underneath. And I don't want to land on somebody's roof. So, like, there's this certain space that I would jump. Okay. Do you intend to jump off the Mid-Hudson Bridge today? Absolutely not. Things are going well at work. I actually met this girl, right? And so he knew how he would die by suicide. He had some thoughts about suicide, but didn't have intent. So the intent is really the key. I like to think of it as like a seesaw sometimes. So protective factors, right? Reasons for living. And I actually ask people, what are some reasons you wouldn't die by suicide today? Because believe me, people have thought about why they wouldn't die, right? People have thought about how to stay alive. That makes sense, right? So I ask them. And healthcare workers in particularly will tell me their job, their patients. Do you know how many people we lose that work in healthcare every day? We lose a physician a day, we lose like 2 nurses, we lose a behavioral health provider, right? A lot of people in healthcare are at risk for suicide. Religion. Pets. Pets, you hear pets a lot. I had a woman tell me, right, she had a pit bull. She said, if I bring him to the shelter, they're going to euthanize him, right? Nobody's going to adopt him. And I always say, you're right, he really needs you. But we train people in animal shelters now to ask. Because if somebody comes in and surrenders, ask them about suicide. Family, right, or kids, and I always reinforce, yes, your children really need their mom. Right? So I try to reinforce. But the way I think about it is a seesaw. So the more intent I have and the less reasons for living, the more at risk I am. The more reasons for living I have and the less intent, then the less risk I'm at, right? So as I'm talking to people, I'm kind of doing the seesaw. And then generally you can tell where people are in terms of risk. If I have reasons for living and I don't have intent, then we're at a different place than we are if I don't have any reasons for living and I have intent. Nobody cares if I'm here. I already gave my pet to the shelter, or my dog passed away. Nobody cares if I wasn't here. I don't have any reasons for living. Make sense to folks? So we're going to talk a little bit about safety planning. Safety planning, we used to do something terrible called contracting for safety. Does anybody remember those? You remember those? Oh, I can't believe we did those. That was so bad, right? I know, we didn't know that's what we did. That's what I was taught to do, right? So we know they're bad. We don't do them anymore. We do safety planning, right? And so much more patient-centered, much better. So if someone is a yellow or orange patient, right, then there's some really good things we can do. The first we can do is give them 988. So you had somebody talk to you about 988. I saw all the stuff, right? 988 is fabulous. 90-some% of the calls to 988 get resolved on that call. They don't need any follow-up. It's evidence-based. It's 24 hours a day. I sometimes have people call right from the office. Why don't you give them a call right here and now? The other thing that I do is I have them put it in their phone. Because 988 isn't in our brains as much as, well, maybe in our brains, but not in everybody's brains like it is 911, right? So I tell them sometimes when you're in crisis, you don't think clearly. Let's put it in your phone. Let's make sure it's there. And have people call, then they know what happens. Have them do it right then and there. The other thing that's really helpful is the Now Matters Now website. How many of you are familiar with Now Matters Now website? Oh, awesome. So Now Matters Now website, same thing, evidence-based. It's there for people 24 hours a day. You should go and peruse it. It's got some really nice stories on it. And so you could talk to people about the different patient stories that are on there. Also has a really nice section for providers. But it is evidence-based, so somebody can have it, use it. So then you've given somebody 2 evidence-based things, right, that are available 24 hours a day. Incredibly helpful for people. I pull Now Matters Now up and we look at it together, or pull it up on your phone. Also, suicide is different. Nice little website for family members, parents, caregivers. Really helpful for them. So this is a safety plan, a version of a safety plan. It's actually on Now Matters Now. And we're starting to think a lot about suicide prevention and fire safety as some of the same. So if you caught on physical fire, what would you do? Stop, drop, and roll, right? I don't know who taught us that. I don't remember the day I learned it, but man, did they do a good job, because we all know it. So however they planned for all of us to know what to do if we caught on fire, that public health message is clear, right? Like, we all know. I've never been in a room where people didn't know that, right? So we all know what to do. Even though the likelihood that we're going to catch on physical fire is pretty low. We all got it down, right? So, but what about catching on emotional fire? We got nothing, right? And so starting to teach the same, even though the likelihood that you're going to catch on emotional fire is low, let's know what to do. Turns out some of the same things work. If I stop, drop, and roll, what am I not doing? I'm not dying by suicide. I'm splashing cold water on me. Actually, physically disrupts my thinking, right? Really, really helpful things to do. I'm looking in someone's eyes, whether it's on my phone or it's a real person. So those are all really helpful things. So I like to give people an emotional fire safety plan. And I tell people exactly like I told you. Listen, you know what to do if you catch on physical fire. Let's know what to do if you catch on emotional fire. You've known what to do about a physical fire for years. You haven't used it yet. Now let's put this on, right? So let's be able to be prepared. And so they're going to really start teaching kids in kindergarten, what do I do if I catch on emotional fire? And I like to give that to patients, even if someone, because someone if I had a history of suicide, like when I was an adolescent, and I tried to die by suicide. I'm old now, right? But I'm at risk for my entire life. I'm more at risk, even though that was a long time ago. So I like to give people an emotional safety plan, no matter what. Everybody should have one. So this is a safety plan. How many of you do safety plans in your role? I love it. So safety plans, we've learned a lot about doing safety plans and what makes a quality safety plan. The first thing we want to do is we want to put people down that we know are going to be helpful to that person, right? But we also want to call them. A lot of times we go and we look at the numbers and they're not even real numbers when we try to call people, right? And so we call people and say, hey, Brianna, you were listed on Virna's safety plan if she's thinking about suicide. And Brianna says, great, I really like Virna and I would love to be a support, right? So then, yeah, or maybe Brianna says, you know what, I would really like to be, but it kind of scares me a little bit. I don't really know what to do. Maybe you go to the Suicide is Different website, and Virna just really needs maybe to have someone talk to her, maybe, or to not be alone, right? Or maybe Brianna says, that's great, except I work in a really busy primary care practice. I can't always pick up the phone. I run out of minutes at the end of the month. When I'm home, right, I don't always have good service. So then we can say, Virna, that doesn't mean that Brianna doesn't care. It means that one of these other things are happening. What if you called 988? Or what if you went on the Now Matters Now website? Or maybe Brianna says, listen, I only met that chick once at a suicide thing. I didn't like her that much. So no, I'm out, right? So then we know that, and we say, well, is there someone else, right? And I've had people say that, right? I've had people say, no, count me out of the safety plan thing, right? And so, yeah, so then we know about it. And that we're making sure, yeah.
I have a question with calling them. What about confidentiality?
I do it with the patient right there when I'm doing the safety plan.
I know if it's an adult that you have a teenager and you're doing your safety plan and the people are on the safety plan and know the parents, it's going to be hard to call them.
Not necessarily, because you got to have people on the safety plan. I ask adolescents, who's on your team? Is there an aunt? Is there a friend, right? Who's on your team? Who can you call? They've got to have people that are able to, that they're able to call.
No, we can't put them on, but I'm calling them.
Yeah, as long as the adolescent is there and you're doing that together, I actually find that it works really nicely, because then the adolescents are more likely to call that person because there's already been a bit of a conversation. So it actually works out pretty nicely. The other thing is around activities. So the thing around activities is activities have to be super personal. They have to be very specific. Like, how many of you on your safety plan might put listen to music? Oh, not as many as I thought. Okay, not very, okay, a couple, right? So I would probably put listen to music. Probably nobody would put listen to Rod Stewart music, if I had to guess, right? Oh, she's making a face, really? Ouch. And so, I'm old, he's from my time. And so, how many of you would listen to Rod Stewart Footloose and Fancy Free album? Nobody but me. Would you? Thank you. I knew, I could tell right from here that we were a kindred spirit. And so, right? But that's because it's personal to me, right? And so if I just see listen to music on a safety plan, I know that there wasn't really a conversation. What music? What playlist? I have people that have suicide playlists on Spotify, right? What playlist? What music? What about that music? What artist? If I don't see that specific, we didn't have a specific conversation, right? And so also activities, a walk. Where do I walk? Why do I walk there? Right? So that you can put something, so that it's very personal to that person. Also, is it something that can happen right away, 365 days a year, 24 hours a day? Is it safe for me to walk in January at 2 o'clock in the morning? Probably not, right? Probably should have a plan B. Am I going to be able to walk if I'm not home, if I'm at school or work, right? So really thinking about that. So if you look at it, and it can happen right away, and it can happen all hours of the day or all days of the year, then we got to think of something else. That can be on there, but you need a backup. And I can tell you, I would say about 97% of the safety plans that I look at when I review charts are not personal. I have a friend that works at Centerstone in Tennessee, and they serve very rural areas in Tennessee, and a lot of the farmers, and she says, I look at these safety plans, and it's like, I'm going to do yoga and journal. And she has said, I have never met a farmer in rural Tennessee who is going to do yoga and journal, right? Like, it's not happening. No, not happening, right? And so it has to be very personal. And so we don't see things that are personal. We don't see things that can happen all hours of the day and all days of the week. So start to really think about what that looks like, because it will change how you do your safety plans. So remember, safety plans are not something perfunctory that we do. I have so many people say, well, I have to do a safety plan. Safety plans are actually a clinical intervention. They save lives. If you go in, I don't know if you know, so Barbara Stanley, who was one of the people, the Stanley and Brown safety plan, Barbara Stanley passed away, I don't know, 5 or 6 months ago now. Huge loss for the field. But there was all of these stories about people who had used their safety plan and it saved their lives. Like personal stories of people who said, I had this, I looked at it, I used it when I needed it. And so really think about that when you're doing them. It takes me a while to do a safety plan. I love to do safety plans because I love really being creative with people. Like, what would be helpful for you? You know? And so it's really interesting. And there's always some things that, because people have thought about it, right? And so, like, why is Walmart on so many safety plans? Open 24 hours a day, you can get there by public transportation. Most of us are fortunate enough to have one in our communities, right? And so Walmart on a lot of safety plans. Also, I was shocked at how many EMR portal is on safety plans, sending a message in the electronic health record. Really, even though people know you might not get it, it helps them feel connected. So super important to think about some of that. Does anyone else have any ideas, things that they've put on safety plans?
I always have them write it in their own hand.
Perfect. Yeah, and then I kind of go with them and say, well, what about that? Or what, is there a particular music or particular artist? Yeah, absolutely. And sometimes it's more than one thing. So I've had someone, and she was at risk when she was driving, and so she said, you know what, I'm going to put pictures on the dashboard, I'm going to carpool 2 days a week, and I'm going to have, call my mom on speakerphone the other days, right? So that she really had multiple things in place for her that she thought of. A lot of times guns are problematic because I can't necessarily take someone's gun because I'm not licensed to have a gun, but I could hold the ammunition. I could also hold the key to the gun lock or to the gun cabinet, right? And so sometimes you have to be a little bit creative in terms of the safety planning. I will ask people, if we did everything that could possibly be done to keep you safe today, what would we have done? What would have happened? And then work backwards a little bit. And oftentimes that's easier for people to think about it that way, because it is super important to understand for people how they would die by suicide. So the interesting thing about lethal means is that if I'm thinking about dying by suicide and using a gun, and we keep me safe from that gun, I'm not likely to switch means. I personally think it's because it gives people hope. My own personal theory, not researched anywhere. So we also want to do it matter of fact. This doesn't mean you won't be able to go hunting in the fall. This doesn't mean that you're never going to be able to have your medications, right? This doesn't mean that you won't be able to drive alone. This doesn't mean you won't be able to have your gun collection back, right? This is temporary. This is what we do for everyone who's at risk. Everyone who talks to me about dying by suicide and using their gun, I make sure they're safe. And then I would really ask people, and then we need to know what the preferred method is so that we can actually ask people. And so oftentimes we worry a lot about the medications that we prescribe people. But I have learned to ask a couple of questions, right? You've talked to me about dying by suicide and taking medications. Where would you get the medications from? Oh, well, my aunt's house, because when my grandma died, she kept all her meds and there's bags of it. Right? So then we need to make sure that we're taking care of that medication, right? Also, don't forget, I've had so many people say, well, actually, I have a CVS down the block. So we know that there's a couple of things that save lives around medication. The individual pill packs. I love Amazon Pill Pack. Because, not only because they send it to me and they put in little envelopes so I remember to take my medication and know if I didn't, which turns out is kind of important, but also because they're in individual packs and we know that saves lives. If I have to open every individual pack, I'm much less likely to overdose and die by suicide. So super important to know. And also talk to your pharmacy now to say, if we had someone that was at risk for suicide, could we get a lockbox? Could we get lesser prescriptions? Could we, so like, what do you do? How do you help people who are at risk for suicide by overdosing on their medications? How can you partner with us, right, to keep people safe? Have that conversation now, because that's really important thing to be able to do. So we talked a little bit about carrying contacts. Carrying contacts are now evidence-based. and they don't have anything attached to them. It's not like you missed your appointment, oh, and I care about you, right? So there's no ask here. It's just literally letting someone know that you care. So it came out of, it's been done internationally, but one of them was in Australia, where people were in the hospital and they would get discharged out and go out into the outback, and we weren't going to see them again. And they would send them a little note, hey, just thinking about you. And they actually reduced suicides. That was enough to give people hope to reduce suicides. So caring contacts often happen the first day. So if I came in to see you and we talked about my risk for suicide, you would just send me a little note. Hey, thinking about you, looking forward to seeing you at our next visit, right, Jacqueline? And you would just sign it, right? Really important to do, really helpful. People really like them. Not attached to an ask. Very important. Here's some different sample ones. And one of the things that I have learned is that they are incredibly important. There's a story that I actually share quite a bit. When I worked in the emergency room and I would discharge patients, I had a little clipboard, and what I used to do is take greeting cards that I got, and that people used to send more cards than they do, but I would tear the back off them. I just have the picture part, and I'd write on it, and I'd throw it in the mail basket. And I would write, really glad we had a chance to meet. Hope this note finds you well, Virna. And I'd just mail it off. And I was in the grocery store with my daughter, and this woman came up to me, and I didn't recognize her at first, and she pulled it out of her purse. Said, thank you for sending this to me. I carry it with me. It's helpful. So that tells you giving someone hope, how much that means, and how life-saving it is. So every one of you has the ability to give someone hope in your storage statements, in your safety planning, in the conversations you have around lethal means, in sending those caring contacts. It makes a huge difference to people and saves lives. And we do not need to send most people to the emergency room. There are some people who do need an alternate level of care. Unfortunately, putting people in the hospital for suicide, it's one of the conditions we hospitalize people for, that we actually don't give them treatment. We're getting better. We are getting better. But not everybody needs to go. I have a lot of people still say, I don't want the liability. You're actually more liable, because now there's evidence things that you can do, evidence-based things you can do in your office. But also, like, we wouldn't imagine somebody coming in with asthma, right? What do we do when somebody comes in with asthma? We might give them a treatment, right? We would ask them questions. Have you used your rescue inhaler? Do you have medications, right? We might give them education. Here's how you use your inhaler or a spacer. We might send someone to their home. We would ask them about emotional triggers or physical triggers, right? We would do an asthma action plan. We might refer them to a pulmonologist. All of these things would happen routinely during the visit with someone with asthma, right? So a lot of those same things for someone at risk for suicide. We don't send everyone that comes in with asthma to the emergency room, because, like, what would happen? After a while, people would say, well, I'll just go right to the emergency room, right, which we don't want. Or, I don't want to go to the emergency room. I don't need to go to the emergency room, so I'm just going to stay home. And then what do we have? We have people with asthma and suicide staying home, which is not what we want either, right? So we really need to make sure that people get the right levels of care, really good safety plans, really good conversations around lethal means, really good conversations around, giving a good caring contact. Does that make sense to folks? Yeah.
So do you have the reference for where caring messages are evidence-based?
Yes, they used to be evidence-informed, and now they have transitioned. Yes, there's a ton. In fact, it's on the Zero Suicide website.
Okay.
Yeah, absolutely. So any other comments, thoughts, questions? Yes.
I was just wondering, on the patient safety plan, is there a US-based website where patients can like send messages or emails? I know the UK has Samaritans.org and you can email back and forth, because patients have asked me, like, they don't want to text or call,
Yeah.
but email is what they want. And I said, well, you could use the UK. I mean, they won't know, it's all anonymous.
Yeah, I don't think there's one that's vetted enough that I would want to say, yeah, to that. Interesting. Any other questions, comments, thoughts?
It's still really hard to put the, the code for suicide intent or suicidal ideation in the chart. And we were just like, yeah, it's kind of, there's still so much stigma, and then, Adele was talking about all the data. So can you talk more about that? Because I know for myself, I'm still really getting used to that thought.
So, first of all, it's really important. There would be no conversation around any other diagnosis that we were treating that we wouldn't put it in the medical chart. I don't necessarily want diabetes in my chart, right? Like, it's really important that any diagnosis that we're treating be in the medical record as a diagnosis that we're actively treating. And I think, there's some interesting conversations around stigma, and I'll be a little provocative here to say the more we talk about stigma and suicide in the same sentence, the more we actually put them together. It's kind of like when you think about the time change, right? The seasonal time change. Everybody blames it on the farmers, but actually the farmers didn't want it. They actually just got lumped so much in conversations that eventually it just got combined, and everybody blamed the farmers, but they didn't actually want it, right? And so I really feel like we are actually perpetuating some if we differentiate suicide and we treat it differently. And so I think giving people a different way to think about suicide and to let people know it's really important that we have everything here that we're caring for you, right? It's really important that we have a list of everything that we're working with you, and suicide is one of them. And also, we are never going to know how many people we have in our organizations at risk for suicide if we don't put it on the problem list. When I worked in the emergency room, they actually told me, don't put suicide as a diagnosis, because then we're going to be liable because you discharged somebody and there was suicide as the diagnosis, which was such crap. Only I was not as experienced then as now. Now I would have absolutely refused to do it. And I would have said, if you have this conversation with me again, I'm actually going to file a formal complaint. Like, you don't want Joint Commission here any more than I do, but I'm going to get them on the phone. Like, I would have absolutely refused to do it. So, Patty, that's probably not all that you wanted to hear. It is hard and it is different, but it's about talking to patients and talking to the team and saying, now that it's on the problem list, this is what's expected when someone comes in for a visit. We ask someone if they're safe. We ask someone if they have their safety plan. This is how we care for somebody at risk. And if it's not there, and I'm on call and covering for you, I might ask different questions or make different decisions if that's on the problem list. But if it's buried in the chart somewhere, I've actually had patients that we've lost to suicide because they were in contact with people and it was buried in the chart somewhere. And no one actually asked them if they were safe, or nobody asked them about a safety plan. And, because it was never someplace where everybody could see it. Yeah. Yeah. Oh yeah. Oh yeah. It's a ICD-10. It's in there. Yeah. Yeah.
HCC code, because we're supposed to chart those.
Yeah.
So, but I dealt with a bunch this past week.
Mm-hmm.
And it was not in the problem list. It wasn't even the diagnosis.
Yeah, and it should be, because we know now too, you treat the suicide risk and not the accompanying diagnosis, right? I used to treat the bipolar and hope the suicide got better. Now I'm treating the suicide. So it's a little bit of a different thought. Yeah.
So I work for a payer, and I'm a quality nurse manager, so I do quality reviews. If we have suicide as a diagnosis on our members, I will we can make sure that our care coordinators were reaching out to those members, and we can say, here you go.
Yeah.
Right now, I catch it on the back end when we get an incident report.
Yep.
Something of that nature, and our numbers are going up, and we cannot affect change.
Yeah.
Without that being on.
That's exactly right. It's exactly right. Yeah.
So how did you flag that, like, if you did a PHQ-9 and that the question about thoughts of harm, and then would you just add suicidal ideation based on?
I wouldn't do it just based on the PHQ. I would do a Columbia scale or an ASQ. And if somebody had intent, then I would definitely put suicide on the problem list. You could also put it in the history if someone had a history, so that it was there on the problem list, but not an active diagnosis. Yeah.
So intent for.
Yeah.
So on the page 26 on your safety plan from nowmattersnow.org,
Yeah.
will you talk to me a little bit about, there was on that second on fire one, there was a statement and I can't get past it. Because somebody with lived experience, it's kind of bugging me, but it says, ignore thoughts that you don't care if you die. And talk me through that. I get the idea of like, let's not make big decisions, but to tell somebody to ignore their thoughts,
Yeah, you know, interesting. So the person who developed Now Matters Now is Ursula Whiteside, and she has a team, and she's lived experience. And so they have actually found it very helpful to tell people, like, don't give those thoughts a voice, right? And I hear what you're saying. To be honest, I think I could go either way. And now that you're kind of bringing it up, I actually don't really focus on that section, and I think maybe I do it for some of the same reasons, so I kind of hear what you're saying. Yeah.
I get the decision making, but that little statement there is like, it almost doesn't fit.
Yeah. You know what I might do actually, if you go to Now Matters Now, you could email her. Okay. And I'd love to hear her response to that. Yeah, no, you could. She would love it. I can tell you for an absolute fact, she would love it. And I'm sure she has a way better sort of thought around it than I'm giving you right now. And I'm going to ask her too, because, yeah. But I hear what you're saying, yeah.
I think that comes though with the CBT and looking at all the thousands of thoughts that we have. And part of the things that we teach is those negative thoughts, you know, it takes 3 positive ones to get rid of a negative one.
Right.
Let that one go, but replace it with something more positive.
Yeah, and I think this doesn't kind of go there. It just says don't think about it, which I kind of get what you're, just don't.
I'm thinking, you're already on fire.
Yeah.
And someone's saying, oh, you're on fire, just ignore the fire.
Just ignore the fire, which I think is not, it's like saying I'm on fire, I'm not going to give those thoughts a voice, I think is the intent.
Right.
But I totally hear what you're saying. Yeah, it's funny. I'm going to ask her. Yeah.
Please.
I think the Suicide is Different website is good, but also to really understand risk and give them some really clear questions to ask. I've taught so many parents, like, be involved in the safety plan. Let's pull out our safety plan. The other thing that I also like with adolescents, because some of them are not as articulate as others, right, is I give them a Likert scale. So 10 is I am on fire. I am on the most fire I could be. And 1 is like, yeah, I'm actually pretty good, right? And so then for them to say, I'm an 8, and then the parents have a response, let's pull out your safety plan, let's make sure we spend time together, let's do this, right? They don't have to articulate a lot. They can just say that or send a text, I'm a 7, I'm an 8, right? That's been really helpful for the adolescents. And then you can give parents, here's the 9 and 10 response, here's a 7 and 8 response, here's a, you know, and then it's kind of like saying, well, how, you know, tell me, where are you? I'm a 6, I'm a 7. Yeah. Yeah, I mean, yeah, exactly. There you go. Yeah, exactly. So we probably have time for one more question, comment. Okay. Well, I appreciate all of you and the hard work that you do. So thank you very much, and all of you have a wonderful weekend.